No, ma'am, it's not visible, ma'am. We are live now.
So I should start.
Yes, ma'am. Monica will introduce you, ma'am.
Yeah. Shall I start, Sahiti?
Yes, Monica.
Good evening, everyone. I am Dr. Monica from Shield Healthcare. I welcome you all for today's session. And I welcome Dr. Asha Roy. She has completed her MBBS from JNU Bhagalpur, and she's a DGO, MD, OBGYN in Ranchi. And today she is going to discuss about adenomyosis. I welcome you, ma'am, and I hand over the session to you.
Hello.
Yes, ma'am.
Hello, good evening. I am Dr. Asha Roy, retired associate professor from PJ Medical College, Dumka. First, I must express my gratitude towards SILTS Connects for supporting doctors in webinar. Today, I am thankful to them for providing me this platform to talk with you. And today I am going to talk about a condition which has been a neglected cousin of the slide is not moving.
Once click on the slide, ma'am.
Today,
Yes.
I am going to talk about a condition which has been a neglected cousin of fibromyoma or fibromyosis, that is adenomyoma or adenomyosis. Adeno means gland and meiosis means hypertrophy of the muscle. So this condition is related to the gland and muscles of the uterus. So adenomyoma or adenomyosis is a disease of uterus marked by diffuse enlargement of uterus, dysmenorrhea, abnormal uterine bleeding, and history of passing clots, especially in late reproductive age group, and it is also known as endometriosis interna. Previously, it was taken as a pathological condition, but now in this modern gynecological era, with available diagnostic imaging facilities, it is considered as a clinico-pathological condition, where there is presence of ectopic endometrial glands and a stroma into the myometrial walls, subsequently leading to hypertrophy and hyperplasia of the myometrium. Rokitansky in 1860 was first to describe about the presence of ectopic endometrium into the myometrial wall under the name of adenomyoma. Von Recklinghausen in 1896 described about the difference between adenomyoma and adenomyosis. When invasion is localized and in one wall of uterus, it is known as adenomyoma, and there is a smooth nodular enlargement of the uterus. Whereas if invasion is found in all wall of uterus, it is known as adenomyosis, marked by diffuse enlargement of uterus. Term adenomyosis was given by Franklin in 1925. Definition of adenomyosis was given by Bird in 1972. That is benign invasion of endometrium into myometrium, producing diffusely enlarged uterus, which microscopically exhibits ectopic, non-neoplastic endometrial gland and stroma surrounded by hyperplastic and hypertrophic muscle, myometrium. Histogenesis. There are several theories of histogenesis of adenomyoma, of which Thomas Cullen's theory is most accepted till date. According to Cullen, adenomyosis results from direct invasion of endometrium into the myometrium. It has been suggested that due to trauma of childbirth, there is breakdown of normal endometro-myometrial border, causing hyperplasia of the basal endometrium, which invades into the adjoining myometrium. It penetrates deeper and deeper and ultimately loses contact with basal endometrium and becomes ectopic endometrium, comprises glands and stroma trapped into the myometrium. During menses, there is growth of endometrial glands and stroma, and there is bleeding within this endometrial tissue. It tries to slough out, but cannot, because this ectopic endometrium has no drainage outlet, as they have lost contact with basal endometrium. Collection of secretion and blood causes pain in the form of menstrual cramps known as dysmenorrhea. This collection leads to hyperemia and congestion of the adjoining myometrium and a stroma, causing abnormal uterine bleeding. Congestion of the adjoining tissue leads to hyperplasia of the adjoining myometrium. With increase in number of childbirth, there is increase in number of ectopic endometrial glands, as there is repeated breakdown of endomyometrial border and invasion of endometrium into the adjoining myometrium. It produces feature of adenomyosis under adverse condition. These ectopic endometrial glands predominantly contains estrogen receptors. So in absence of progesterone receptor, there is unopposed estrogenic reaction on these trapped endometrial glands, leading to hyperestrogenemia, which produces the feature of adenomyosis. Most recent theory says about the changes in spiral arterioles during menses in the early reproductive life. There is a special priming effect of spiral arterioles on angiogenesis during menses, which allows the penetration of endometrium into the myometrial wall. Of all the hypotheses, Coulin's theory is most accepted till now. Risk factors. The risk factors are fertility. Recurrent childbirth leads to breakdown of an invasion of the endometrium, so there is risk of adenomyosis with each childbirth. It usually affects the multiparous women. Early menarche. Frequent menstruation due to short cycle, previous cesarean section and traumatic delivery, repeated curettage and recurrent abortions, drugs, antidepressant causing hyperprolactinemia. Tamoxifen, an estrogen agonist, has estrogenic reaction on endometrium leading to hyperestrogenemia. The associated conditions are fibromyoma in 35 to 55% cases, pelvic endometriosis in 25 to 70%, endometrial hyperplasia in 7%, endometrial polyp in 1 to 4%, endometrial carcinoma in 1 to 3%. The all associated conditions have one common underlying disorder, that is hyperestrogenemia. Grading. Various investigators have worked upon the invasion, depth of invasion, and they provided the grading of this pathology. Molitor's grading depends upon the depth of penetration. Grade 1, when the invasion is up to the inner 1/3 of myometrium. Grade 2, invasion up to the middle 1/3 of myometrium. And grade 3 is invasion up to the outer 1/3 of myometrium. Again, Bird has given a grading depends on the number of glands per low power field. Grade 1, that is mild, the number of gland is 1 to 3 per low power field. Grade 2 is moderate, and the number of gland is 4 to 9 per low power field. Grade 3 is severe, and the number of glands are more than 9 low power field. Prevalence. The prevalence published report has great variation from 40 to 70%. It has been reported after the examination of cut sections, and it depends on age. It is prevalent in the late reproductive life, mostly after 35 years. Parity, mostly affecting the multiparous women. Availability of advanced diagnostic imaging facilities has increased the rate of prevalence by increase in the diagnostic data reports. Histological examination of the cut section, higher is the number of cut section, higher is the rate of prevalence. Pathology. The gross naked eye appearance, uniformly enlarged uterus in 60 to 80%. Asymmetrical enlargement in adenomyoma, focal, or if associated with fibromyoma. Usually does not exceed the size by 12 to 14 weeks size. Size may exceed if it is associated with fibromyoma. External surface is smooth and regular. Surface shows patchy pink area of congestion and hyperemia. Cut section. Naked eye examination. Myometrium shows hyperplasia and thickness of myometrium. Posterior wall is thicker than the anterior wall. Surface shows trabecular or granular appearance, and normal contour of myometrium is lost. Small dark spots of cystic areas with secretion of dark fluid or old bloods are present, giving a typical burn matchstick appearance. On pelvic examination, uterus is diffusely enlarged. It is globular, boggy, and soft in consistency. It is soft and tender. Typical Haben's sign is present. It may feel nodular if it is localized or associated with fibroid. Microscopic feature. According to Novak and Woodruffs, they have suggested the presence of endometrial gland and a stroma per high power field below the basal endometrium, where Benson and Sneeden, according to them, the presence of endometrial stroma and glands at least 2 per low power field beneath the basal endometrium. Clinical types are diffuse adenomyosis involving the all wall of uterus and large area of myometrium is affected. Focal adenomyoma localized with comparatively clear border affecting a small area of myometrium. Polypoidal adenomyosis. When there is adenomyotic changes in the polyp, it is known as the polypoidal adenomyosis. Endocervical adenomyosis. When it is placed in localized area of endocervix. And retroperitoneal adenomyosis usually arises from the remnant of the mesenchymal tissue. Histological variations are from solid to cystic. Symptoms, 50% cases are usually asymptomatic. The most important symptom is dysmenorrhea. Typical dysmenorrhea is the classic feature of adenomyosis. Both spasmodic and congestive dysmenorrhea are present in all premenstrual, menstrual, and postmenstrual phase of cycle. Abnormal uterine bleeding with history of passing clots. Premenstrual spotting is present in 15 to 20% of cases. Few patients may complain of dysmenorrhea. It indicates about the association of pelvic endometriosis. Chronic pelvic pain is either due to inflammation or if associated with PID. The typical symptoms includes pelvic pain, dysmenorrhea and menorrhagia, unresponsive to hormonal therapy or uterine curettage, subfertility, and pregnancy terminations often found. Clinical presentations are cyclic cramping uterine pain beginning later in reproductive life, generally after 35 years, and often associated with prolonged and heavy menses. Adenomyosis and subfertility. There is not much debate on this subfertility, fertility and adenomyosis, but definitely there is subfertility. The causes of fertility are impaired sperm transport due to altered uterine peristaltic activity, impaired implantation due to increased junctional zone thickness. Implantation rate is inversely proportional to the junctional zone thickness. It has been suggested that junctional zone, if junctional zone is less than 10 millimeter, the implantation rate is 45 to 50%. But when it is junctional zone is 10 to 12 millimeter, it comes down to 15%. And when junctional zone is more than 12 millimeter, it drops to 5% only. Impaired endometrial receptivity is also one of the cause. Abnormal vascular proliferation and increase in junctional zone thickness is the main cause. Normally it is 4 millimeter with variation up to 1 to 2 millimeter in various phases of menstruation, but it increases up to more than 12 millimeter in adenomyosis. Changes in endometrium due to adverse molecular factors like vascular endothelial growth factor. There are changes in vascular arrangement of the endometrium and myometrium both. Changes in myometrium, that is in the individual muscle fibers, and gene dysregulation is also there. Uterine peristaltic activity originates exclusively from the junctional zone, while the outer myometrium remains quiescent. During the follicular and periovulatory phases, contraction waves have a cervico-fundal orientation, and their amplitude and frequency increases significantly towards the time of ovulation. It is impaired in adenomyosis due to changes in muscle fibers of the myometrium. Role of peristaltic activity is significant in proper endometrial differentiation, normal menstruation, helps in sperm transport and implantation. Adenomyosis and pregnancy. Adenomyosis is frequently found in pregnancy, but has no untoward seldom effect with the obstetric and surgical outcome. Childbirth increases the risk of endometrial hyperplasia and there is invasion. So it is one of the risk factor for adenomyosis. The incidence of rupture of uterus increases due to changes in myometrium because of atony of the muscle that is caused by decidual transformation of adenomyotic foci, atrophy of the muscle fascicles, edema of the stroma, mesenchymal transformation, and fibrosis. This all leads to weakness of myometrium, which is the cause of rupture of uterus and atonic PPH. Diagnostic investigation. Abdominal ultrasonography, transvaginal sonography, hystosalpingography, myometrial biopsy, CA-125 estimation, and MRI. Ultrasonography. Sometimes no abnormality is found and uterus may be of normal size. There is focal or diffuse bulkiness of uterus, especially of the posterior wall. Thickening of the transitional zone might be visualized as the hypoechoic halo surrounding the endometrium, which is of more than 12 millimeter thickness. Color Doppler findings may show a hypoechoic area with devoid of vascularity. There might be irregular vessels around endometrial stroma if the probe is passing through the adenomyotic area of the uterus. Transvaginal sonography. It can show a clear area of adenomyosis. It can differentiate between adenomyosis and fibromyoma in more accurately in 90% cases because of presence of capsule and peripheral vascularity in fibroid. Hystosalpingography. The classic findings are multiple spikes of 1 to 4 millimeter extending from endometrium to the myometrium and terminates into a small sac. Honeycomb appearance of the myometrium. Non-specific, as they can appear in lymphatic and vascular extravasation. So it is not in very much use in clinical practice. Myometrial biopsy. Pop has done plenty of work on myometrial biopsy, but the reports are quite frustrating. It is done during laparoscopic surgery or under guidance of ultrasound. Tiny muscle fiber biopsy pickups report only 8 to 20% women with adenomyosis. Sensitivity of this method is quite low for clinical practice. CA-125 estimation. CA-125 antigen are estimated. Due to inflammatory reaction, there are increased number of macrophages in the myometrium that leads to free circulation of CA-125 antigens into the peripheral circulation. It may show a high level, but of no significance because high levels are found in other conditions also, like leiomyoma, ovarian neoplasm, and other condition also. The current study has shown the difference of morphological structure of nucleus of ectopic endometrium from eutopic endometrium. If it can be separated to see the differences in morphological structure of this antigen, it can be of great help in diagnosis by screening out regularly. MRI is better option than other methods. There is homogeneous junctional zone thickness with high echogenic signals, high signals of myometrial spots suggestive of adenomyosis. Junctional zone. The endomyometrial junction zone proliferates maximum between 8 to 16 days. Normally it is of 4 millimeter thickness with variation of 0.9 millimeter in different phases of menstrual cycle. Thickness more than 12 millimeter is suggestive of adenomyosis, although in 20% women of perimenopausal group, it has been found to be absent. Thickness less than 12 millimeter is also suggestive of adenomyosis if other myometrial criteria such as high signal spots or irregularly bounded junctional zone is present. The foci of hemorrhagic spots corresponds to the heterotopic endometrial tissue, cystic dilatation of the glands, or hemorrhagic area of adenomatous foci. MRI is more accurate and superior than ultrasonography. Homogeneous junctional zone thickness more than 12 millimeter with hemorrhagic high signal myometrial spots is highly predictive of adenomyosis. On T2 weighted MRI, focal adenomyosis are seen in areas of abnormal low signal intensity within the myometrium and in approximately 50% of the patients. These foci corresponds to islands of heterotopic endometrial tissue, cystic dilatation of heterotopic glands in adenomatous foci. On T2 weighted MRI, diffuse adenomyosis usually manifests in diffuse thickening of the junctional zone with homogeneous low signal intensity. T2 weighted imaging facilities significantly better lesion detection than unenhanced or contrast material enhanced T1 weighted imaging. Classification on the basis of adenomyosis with MRI on the uterine junctional zone. Simple junctional zone hyperplasia. Zone thickness is more than 8 millimeter, but less than 12 millimeter on T2 weighted image in women aged 35 years or less. partial or diffuse adenomyosis, thickness of junctional zone 12 millimeter, high signal intensity myometrial foci, involvement of the outer myometrium depending on grading might be less than 1/3, less than 2/3, or more than 2/3. And adenomyoma, myometrial mass with indistinct margin of primarily low signal intensity on all MRI sequences. Management, conservative treatment, medical treatment, and surgical treatment. Conservative treatment, it is symptomatic treatment with painkillers, hemostatic drugs like tranexamic acid and mefenamic acid. Medical management is progestin, medroxyprogesterone oral or intramuscular to reduce the hyperestrogenemia. Progestin emitting IUCD reduces the vascularity and hypertrophy of myometrium, leading to reduction in size as well as from menstrual symptoms. Oral contraceptives combined, given for 90 days in continuation, followed by gap of 7 days for withdrawal bleeding. It reduces the number of menstruation, thereby reducing the menstrual symptoms. Drawback is it may aggravate the hyperestrogenic state. GnRH agonist, leuprolide 3.7 milligram IM monthly for 6 months, or 0.5 milligram subcutaneously daily for 6 months. Not very popular as recurrence of pathology after withdrawal of treatment. However, it is favored preoperatively as it reduces the vascularity. By that, imminent bleeding is reduced. And due to amenorrhea, there is correction of anemia also. Danazol, loaded IUCD. Based on the study reports of researcher, it has been found that among the patients who are resistant to GnRH or oral danazol can be treated with danazol-loaded IUCD. The subjective and objective signs and symptoms of adenomyosis were reduced or eliminated in most of the cases within minimum amount of time, mostly in 85 to 90% cases. Fertility may be restored after removal of the device, but it is still to be reported. There is no systemic effect of danazol as it remains concentrated in the uterine area. Valproic acid. Few studies have been done on the off-label use of valproic acid, but further studies are needed. If this research becomes successful, it will be a better option than GnRH and danazol. Surgical treatment. Complete excision of adenomyosis, preferably done for localized adenomyoma. It can be done in selected cases of diffuse adenomyoma with reconstruction of uterine wall meticulously. All clinically recognizable adenomatous foci should be removed meticulously. Reconstruction of myometrium is done by U-shaped incision and closure after approximating the layer of myometrium. Seromuscular layer can be overlapped and sutured to counteract the lost middle layer. Triple flap method is obsolete now. Each conservative surgery of adenomyosis gives a partial result because in spite of meticulous surgery, some amount of adenomatous foci remains left behind. Moreover, excision of adenomatous tissue is always accompanied by excision of portion of normal myometrium. So somehow it is a destructive surgery. Other surgical options are cystectomy. It is useful in complete excision of cystic adenomyoma. Cryoreductive surgery done in diffuse adenomyoma. Adenomyosis, partial removal of clinically visible lesions followed by random suturing of the excised cavity of the myometrium. Of course, it is not very popular. Non-excisional techniques are uterine artery embolization, done under fluoroscope control. Catheterization of both femoral arteries done under spinal or ether anesthesia. Percutaneous catheter is passed through the internal iliac artery and from there is to uterine artery supplying the myometrium. Embolus of PVA 500 to 700 pellets or triacryl gelatin microspheres are injected into the artery. Duration of surgery is 40 to 50 minutes. Success rate is 25 to 80%, done by interventional radiologist. It is getting popular in higher centers where these facilities are available. Complications of this are necrosis may get superinfected, pyometra or other late complications may occur. Fertility may be restored after 1 year, but is still debated. If any treatment is not responding or not feasible, then hysterectomy is the choice of treatment. Thank you. All right. Am I audible?
Yes, ma'am. Thank you,
Yes,
ma'am.
ma'am. Thank you, ma'am. Ma'am, we have a few questions from our audience. Shall I repeat those questions?
Okay.
Do exercise reduce adenomyosis? This is the first question we got, ma'am.
What is? Sorry?
Does exercise reduces adenomyosis?
Adenomyosis, what?
Symptoms, ma'am. Does exercise reduces adenomyosis symptoms?
Exercise.
Yes, ma'am. Exercise
Yes, ma'am.
reduce adenomyosis symptoms.
Sorry. I am not able to understand the question.
Monica, can you please type in chat box?
Yes, yes.
Oh, exercise, it might be in very early stage, you can go for that, but if there is menorrhagia or passing of clots, then it will not affect, it may aggravate also. If it is asymptomatic and it is diagnosed randomly during outdoor, then you can go for exercise. But otherwise, it is not very helpful. It is not very helpful in symptomatic cases.
Okay, ma'am. I hope the audience who have asked this question understood this one. And the next question is, surgical removal of adenomyosis improves fertility outcome. What is your opinion on this, ma'am?
If it is done in very meticulously, I have seen in adenomyoma, it has improved the infertility. But in adenomyosis, it is very difficult because there is distortion of the myometrium as well as endometrial cavity also. So there is always poor outcome, and it may aggravate the adenomyosis also. Fertility is depending on the grading. Fertility depends on the grading. If it is grade 1, then fertility rate is definitely high. If the junctional zone thickness is less than 10 millimeter, then fertility rate is high. If there is no severe vascular changes in the endometrium, then implantation rate is high. So it depends on the grading.
Okay, ma'am. Ma'am, we have 2 questions only. Thank you for answering this elaborately, ma'am. Even they have understood, and even I understood, when we should undergo surgical method for adenoma and adenomyosis. Thank you so much, ma'am, for this informative session today. And I hope we do more and more webinars with Shield Healthcare in future too.
I'm really thankful to you people
Thank you
for
so much.
giving me
Yes,
technical support, although I'm not very much familiar with my laptop. It was very difficult. There was no video. So I'm sorry, very sorry. Later on, I will try
but the
to
session was
appear.
fantastic, ma'am.